Begin the next session if you wouldn't mind trickling back into your seats. It's a great honor to be moderating this next scientific session with some great papers spanning across our discipline. Just to introduce ourselves, I'm Insoo from NYU.
I'm Sophie Dream from Medical College of Wisconsin.
Again, a great pleasure to be here with you. Just a few reminders again for the presenters to please keep to your allotted time. We'll give you maybe some aggressive hand signals if you're going a little bit late. And then secondly, for the audience members, again, a reminder, if you were to come up to the microphones, please clearly announce your full name, first and last name, institution, and then lastly, if you have any conflicts prior to your question. So without further ado, we'll just get started. The first paper for us is going to be presented by Dr. Ginzberg, representing other authors Kalva, Wirtalla, Passman, Xueyan, and Wachtel from the University of Pennsylvania. And the title of the paper is called Development of a Risk Prediction Model for Primary Aldosteronism in Veterans with Hypertension.
Thank you very much for the opportunity to present today. Primary aldosteronism is a condition characterized by the autonomous production of aldosterone from the adrenal glands, and it can be due to either unilateral or bilateral disease. Primary aldosteronism contributes to significant morbidity and mortality in the United States. We know that approximately half of the US adult population has hypertension, and of those patients, approximately 20% are treatment resistant. Within that group, primary aldosteronism accounts for up to 20% of those patients. And importantly, patients with primary aldosteronism have an increased risk of stroke, coronary artery disease, and other comorbidities compared to patients with essential hypertension. And we know that it's critical to distinguish between the causes of hypertension because the treatment of primary aldosteronism is different. To that end, guidelines from the Endocrine Society recommend screening for primary aldosteronism in any patient who has treatment-resistant hypertension or hypertension with hypokalemia. However, several recent studies have revealed that only a small fraction of eligible patients are actually getting tested. And we think there are many reasons for this, which include the lack of familiarity amongst primary care clinicians with these guidelines, false perceptions about the disease rarity, and prioritization of other medical issues during visits. So because of this, our research group came up with the following question. Can we use an electronic health record-based decision support tool to pragmatically increase rates of screening and then subsequent treatment for primary aldosteronism? And so we designed this study with three components. First, we developed a prediction model to identify the patients who are most likely to screen positive for primary aldosteronism using readily available characteristics that we can extract from the EHR. Now we are in the phase of integrating the prediction model into the EHR so clinicians can be prompted to order screening automatically in patients who are identified as high risk. And then finally, we'll take this a step further and actually facilitate specialist referrals for management of patients who end up screening positive for the disease. And this afternoon, I'm really going to focus in on this first part, which was critical to the success of the study overall because, as I mentioned, with only 2% of patients being screened, there's a huge burden of patients who should be screened. And if we suddenly brought all of those patients into the system, we would overwhelm our specialists and their ability to care for these patients. So we really wanted to start by focusing in on the patients at highest risk of testing positive and those who are going to be most likely to benefit. So we used a VA data set of patients who were identified as having hypertension. And then we identified those who were eligible for PA screening either due to treatment resistance or concurrent hypokalemia. To develop our prediction model, we first took the screened patients and split them into a development cohort and a validation cohort. We then used logistic regression analysis to identify characteristics that were associated with testing positive for PA and folded that into a multivariable model that we then used to create a risk scoring system to predict the likelihood of testing positive for PA. And we assigned a number of points based on the strength of the association between the characteristic and testing positive. We then tested the performance of our model by calculating the proportion of patients who actually in fact had PA and those who were predicted to have PA at each of the risk scores. And we did this for both the development cohort as well as the validation cohort. So of the 1 million patients in the VA data set who had hypertension, 500,000 were eligible for PA screening. And about half of those met criteria for having resistant hypertension and the other half because they had hypokalemia. The mean age of our cohort was 63 years, and the vast majority of patients were male, again, as this was a VA data set. You can also see there was a slight overrepresentation of patients identifying as Black race. Only 1.6% of our cohort underwent PA screening, but of those tested, 15% tested positive. Here you can see some of the clinical characteristics we were looking at. And I'll just point out here, these laboratory values that we were looking at were the most recent outpatient testing that the patient had prior to becoming eligible for screening. And then these clinical comorbidities were identified based on ICD diagnosis codes in the patient's chart. So admittedly, there may be some underreporting here if clinicians didn't take the time to actually put them into patients' past medical history. Here are the results of our multivariable prediction model, and you can see that many of the characteristics we were looking at were in fact associated with testing positive for PA. Specifically, we took these 6 characteristics: young age, obesity, a lack of a smoking history, resistant hypertension, hypokalemia, and elevated serum sodium, and rolled those into our risk prediction model. You can see here, these are the points that got assigned based on the strength of the associations. And we were able to come up with a risk scoring system that had a total of 9 possible points for each patient. When we applied our risk scoring system to the development cohort, most patients received a score between 1 and 3. 6.5% of patients got a score of 0, and 1% received a score of 8 or 9. And now we apply that risk score and look at the proportion of patients who did in fact test positive for PA and compare that to the proportion that were predicted to test positive for PA at each score. And so the observed cases are here in light blue, the predicted cases in dark blue, and you can see in both the development cohort and the validation cohort, we had a really nice correspondence between those two groups, suggesting that this risk score does indeed stratify patients quite well. So in summary, these are 6 key predictors of screening positive for PA, and when taken together, they can be used in a pragmatic risk scoring system to identify patients at highest risk. Furthermore, in our risk scoring system, having a score of 4 or greater meant that the patient had a greater than 20% risk of testing positive, which was a higher prevalence of disease than just looking at patients with treatment resistance alone. So in conclusion, this risk score, which uses readily available EHR-based data, can identify patients at highest risk of testing positive for PA and can be used as a first step to increase screening by really focusing in on these patients who are most likely to benefit as we are looking at overall such significant rates of undertesting. And that will help health systems manage resources as we bring these patients into the system. Of course, there are several limitations to the study. First, we used a VA cohort, which doesn't necessarily reflect the overall American population. Additionally, there is bias in screening, and so if there's bias in screening and we use the screened patients to create the prediction model, that may also introduce bias into the model itself. And so that's something we're going to go into more in our manuscript. And then again, the use of the ICD codes to identify the comorbidities, that may be underreported. In terms of where we're going from here, we're currently in the process of validating this risk prediction model in a non-VA data set using our own health system data. And then we've received approval from our health system to actually go ahead and integrate this into the electronic health record so that it can create a decision support tool for the busy primary care clinicians that we work with and prompt them to go ahead and order screening in these highest risk patients. So with that, I will thank my team and I'm happy to take any questions.
Excellent job. This paper is open for questions. I think Dr. Du beat everyone to the punch.
Quang Du from San Francisco, wonderful presentation. Aldosteronism is one of the underdiagnosed and undertreated disease that we have in endocrine surgery, so I really applaud you for doing this. My question for you is that have you or were you able to sort out the surgically treatable versus medically treatable disease? Of course, they're both problems for the patient and need to be treated appropriately. But as surgeons, obviously we're more interested in those that we can just fix them with an operation. And the general impression in the literature and our own experience is the more severe the disease, the more likely it to be surgically treatable. And so were you able to look into that with the patients that you have?
Thank you very much for that question. So unfortunately, we haven't gotten quite there yet. So this risk prediction model is upstream, and it's just that very first step of saying, let's send the blood tests. And from there, the next piece, as I foreshadow, is that we're going to actually have a way to facilitate referrals for these patients who test positive. I think one of the big problems is primary care clinicians don't necessarily know what to do with the results when they get them. So that's going to be built into our decision support process to help get them the additional testing they need and then the appropriate treatment.
So maybe I'll just make another comment. Historically, many years ago, about 2/3 of patients identified with aldosteronism were surgical. With heavy screening, that dropped to about 1/3. So you can tell in your own institution whether you're underdiagnosing your patient or not just by looking at that proportion.
Thank you.
Dr. Nilabal?
Hi, Naris Nilabal from NIH, no conflict of interest. I think the word test positive really depends on what you use as a gold standard, right? Annals of Internal Medicine 2020 published that when you compare prospectively 1,000 people with hypertension and normotensive patients, if you compare PR ratio to the salt loading test, the ratio did poorly. And most of aldosteronism is under-recognized. So the question is, what did you use as a test positive? What's your definition?
Thank you very much. So absolutely, there are slight variations in the definition in the literature. The definition we used for this study was from the Endocrine Society guidelines that I mentioned from 2016, and the details of that will be in our manuscript. Thank you.
Dr. Noyaku?
Thank you. Fiema Wariaku, Salt Lake City. Great study. My only question is, are there opportunities in your data set to look at other confounding variables, say people on ARBs and things like that? Because are these variables you selected pre-selected, or when you try the development phase, you use the machine learning component or not?
Thank you for your question. So the creation of this data set involved a lot of manual chart extraction, and so the variables that we were able to use were things that were already sort of determined. And unfortunately, one of the things that we were not able to look at was timing of medication use, whether medications were held before testing and things like that. So unfortunately, that is a limitation of this data set.
Very quickly, Dr. James?
Ben James, Boston, no conflicts. I have more of a philosophical question. It's clear when you've got 15,000 patients that were tested positive and ended up being screened for this. I just wonder whether, instead of trying to narrow the population that's screened because of this issue of lack of screening, we should be working on ways to actually expand the screening instead of narrowing it. And if you are going to narrow it, maybe focus on things like the aldosterone resolution score to focus on people that you think might benefit from surgery rather than the population as a whole.
Thank you so much for that comment. I think in the long term, that's definitely the goal. In the short term, this is part of a practical quality improvement project that we're doing within our own health system. And just looking at the number of patients out there that need screening and we predict will subsequently require treatment of that cohort, we just feel that we do not have the capacity to deal with those thousands of patients all at once. So part of the reason for narrowing it just at this phase is to bring that first group of people in who are most likely to benefit, but agreed in the long term, we would definitely like to capture everybody who deserves to be screened. Thank you so much.
Thank you.
Our next presentation is generating a multimodal artificial intelligence model to differentiate benign and malignant follicular neoplasms of the thyroid, presented by Dr. Lin on behalf of Drs. Liu, Lee, Fernandez, Ranvier, Tay, Owen, Matson, and Lee from the Icahn School of Medicine in Mount Sinai.
So thank you to the Society for this opportunity. My name is Ann Lin. I'm the Endocrine Surgery Fellow at Mount Sinai, New York. The authors have no disclosures. So the use of artificial intelligence in healthcare has exploded in recent years, has been shown to be able to pass medical and law exams and have applications in both clinical medicine and physician well-being. There have also been countless viral photos, videos, and artwork all generated by AI, including this photo of the Pope decked in Balenciaga. So artificial intelligence refers to any study of machine imitation of intelligent human behaviors. Machine learning is a subfield of AI and is a collection of algorithms that can extract meaningful features and patterns from a data set without being explicitly programmed. When applied to medical imaging, machine learning has the potential to unlock diagnostic features missed by manual analysis and can be tasked to create binary classifications. So some background. There's a high incidence of thyroid nodules in the general population, and workup typically begins with ultrasound. However, there still exists significant subjectivity and inter-observer variability in thyroid ultrasound interpretation, and currently available risk stratification systems only provide some guidance. So the improved classification of thyroid ultrasound images has been a particular area of focus in AI research. There have been previous machine learning models tasked to classify thyroid nodules as benign versus malignant using ultrasound images. However, few have focused on specific subtypes. So follicular carcinomas comprise about 5 to 10% of differentiated thyroid cancers and cannot be differentiated from benign adenomas by human interpretation of ultrasound, and diagnosis relies on pathologic confirmation of capsular and vascular invasion. Thus, the application of traditional machine learning models that are based on imaging features alone in this specific subtype may pose a particular challenge. The incorporation of multimodal data may be one way to improve predictive accuracy. By using multiple data types as input instead of just one, for example, imaging, demographic labs, clinical notes, real-time trends, and genomics, this type of data fusion better mimics the actual process of clinical decision-making. Previous studies of multimodal machine learning models have demonstrated higher predictive accuracy than unimodal models. So we want to investigate the novelty of a multimodal approach in follicular thyroid neoplasms. The aim of this proof of concept study was to develop a multimodal machine learning model tasked with classifying follicular carcinoma from adenoma in a study population of patients who had undergone thyroid surgery and to evaluate its predictive accuracy compared to single data type machine learning models. We queried our Mount Sinai data warehouse for adult patients who underwent thyroid surgeries between 2010 and 2022 and selected patients with final histopathologic diagnosis of follicular adenoma or carcinoma. Patients who had prior history of thyroid cancer, multiple cancer diagnoses in the pathology, or no preoperative imaging available were excluded, and we ended up with 7 patients in the adenoma cohort and 11 in the carcinoma cohort. So first, we started with image segmentation. All preoperative ultrasound images were downloaded, and all images that included the nodule of interest were annotated like this. These annotated images were used for radiomics analysis, which is the quantitative analysis of high-level textural features of images, and a total of 910 radiomics features were extracted. T-distributed stochastic neighbor embedding was used to non-linearly reduce the dimension of these extracted features to 2 represented components. For model development, these 2 data types, the imaging components and the clinical variables, were used as multimodal input into a random forest classifier. A random forest classifier is a machine learning algorithm that involves training multiple decision tree classifiers, then averaging each prediction from the individual classifiers to create a final prediction. Finally, leave one out cross-validation was used to evaluate our model performance. So for our results, in our comparative analysis between our adenoma and carcinoma cohorts, there was no significant difference in baseline clinical demographic variables. There was also no significant difference in BMI, positive family history, largest size, and volume of nodule on ultrasound. There was significant difference in Bethesda classification with higher classification of the carcinoma cohort. And the percentage of known positive mutation status was higher in the carcinoma cohort. So note, this variable was not included in our model as we had multiple patients missing this data point. And then additionally, size of the nodule in pathology was also significantly larger in the carcinoma cohort. So this graph displays the feature importance score of our clinical RFC model, with size of nodule in pathology showing the highest score, meaning the algorithm interpreted this as the most predictive clinical variable contributing to classification. This is then followed by BMI, then volume of nodule on ultrasound, size of nodule on ultrasound, and Bethesda classification. So while it makes sense that increasing size of nodule correlates with risk of malignancy, the discrepancy between the predictive power of the radiographic versus the pathologic size really highlights again the inherent subjectivity of ultrasound interpretation. Here, the receiver operating characteristic curves of our models are shown. The area under the curves demonstrate improved performance of our multimodal at 0.792 to clinical only 0.759 and image only 0.260. This represents the benefits of combining imaging features and clinical variables. So why did our image-only model perform so much worse than the other two? So this can again highlight the difficulty of distinguishing follicular thyroid lesions on ultrasound, or it can point to variability in our ultrasound images, or point to problems in our model development. So specifically, it's possible that radiomics was unable to capture the distinction between follicular carcinoma and adenoma, and another methodology, such as deep learning, could better extract those features. So deep learning is a method of using many artificial neural networks to mimic the learning process of the human brain. Specifically, it can extract imaging features from raw input images, therefore eliminating the human bias of manual annotation. So there are several limitations to our studies. We did use a small number of patients, which limits the generalizability of our model. There was variability in quality of ultrasound images, with ultrasound images being downloaded from multiple machine types from different institutions. The inclusion of post-operative variables really precludes our model from being clinically applicable and making pre-operative predictions. And we did not compare to radiologist controls or risk stratification systems, and so we can't comment on our model's performance against currently available means of evaluating thyroid ultrasound. So however, despite these limitations, we do believe that our proof of concept study helps support further investigation into this approach. Areas of future exploration and model input include using pre-operative data alone to develop a multimodal model as a prediction tool. Using large multi-center data sets will improve generalizability, and exploring the predictive impact of specific mutation types should be undertaken. In model development, different machine learning methodologies such as deep learning should be explored, and future studies should incorporate robust validation using external data sets. Finally, this approach can really be applied to countless diagnostic dilemmas. So in conclusion, our study highlights the novelty of implementing a multimodal approach, demonstrating greater predictive power in comparison to image alone or clinical variable alone models. Future studies can apply this approach to generate models for preoperative differentiation between follicular thyroid neoplasms. Thank you so much, and I welcome any questions.
Thank you for the excellent presentation. We'll start in the back of the room on the left.
Mahsa Javid, I'm from the University of Louisville, no disclosures. Thank you for that exciting talk of proof of concept. I feel that our profession is very much in the business of...
Oh my God.
I was going to say risk. So in terms of doing... In terms of balance, like how much to shout over the... I'm just wondering, what do you feel is the endpoint? Like, do you have a particular...
I think we'll wait. I don't think anyone can hear. Yeah. I think we can go.
No.
cause of the alarm. Please remain calm. Further announcements will be made shortly.
We have people looking into it. It's probably similar to what was
May we have your attention, please? May we have your attention, please? Trained hotel personnel are informing the cause of the alarm. Please remain calm. Further announcements will be made shortly.
We should give it a minute until we are sure
Sure.
the alarms are off to be respectful to our presenters in question.
We may just slightly curtail the discussion, but we still obviously want to hear the question. I think we can
I
go.
think you're good, yeah.
At some point, you're going to come up with an algorithm that is pretty good, maybe that's slightly worse than FNA, maybe just as good. And I'm just wondering, people don't like to have their necks have needles inserted into them. So do you have a vision or cutoff of when is your algorithm good enough to not do FNA?
So we actually did consider that in future directions. I think that's really important, and we could even create a model that doesn't include FNA data alone and actually compare it to FNA accuracy. And ultimately, I think these need to be compared to the data that we have. So for example, I mentioned that we didn't compare to the radiologist controls or any of the risk stratification systems. And so ultimately, if we are able to create a model, then we have to compare it to the FNA accuracy. And I think in the future, hopefully we'll be able to do that.
Oh, one more question. Yeah, go ahead.
Quick question. Nurse Nillable NIH, I still remain calm. So I know nothing about AI, but I do know a little bit about statistics. I think what you said about the ROC curve of the imaging studies, that 0.28, it's actually pretty good. It's actually, if you invert it, whatever you looked at, you have 0.72 of the ROC curve on the other end. In other words, whatever you did, flip it, and you have the same prediction model as the other ones.
That's definitely very interesting to think about. I think, based on the model, those were the results that we had. And I think that's why we focused on just that modest, improvement of the multimodal over the clinical and the image only. But that's very interesting. I would look into that further, yeah.
All right.
Thank you so much.
The next paper is going to be presented by Dr. Finn, representing other authors Sharp, Krumike, Ginzberg, Sogard Ballister, Tong, Wachtel, Fraker, and Kells from the University of Pennsylvania, Massachusetts General Hospital, Brigham and Women's Hospital. And the title is called Cost and Utilization of Same-Day Surgery versus Overnight Admission for Total Thyroidectomy, a Multi-State All-Payer Analysis. Dr. Finn.
Thank you. Thanks for the opportunity to present our work. Is this fine? Oh, we've got no conflicts of interest to disclose. Surgical care has increasingly shifted to ambulatory settings due to potential advantages of increased patient comfort, cost savings, and reduced use of inpatient resources. This trend has also been observed among thyroid surgery. This shows partial and total thyroidectomies among NISQIP hospitals between 2005 and 2014, showing that just under a quarter of partial and totals were done on a same-day discharge basis in 2014. To guide practice during these changes in care, the ATA released a statement on outpatient thyroidectomy in 2013, defining eligibility criteria and relative contraindications. However, same-day discharge after total thyroidectomy remains controversial among this community. These data were shown here last year, showing that among programs with endocrine surgery fellowships, practice patterns are highly variable, with some fellowships doing outpatient total thyroidectomy on nearly 0 of their patients and some on almost all of them. So that really inspired us to ask the question, what's going on the population level? So for this study, we had 2 aims. First, we wanted to evaluate the temporal trends and length of stay in an all-payer, multi-state cohort of patients who underwent total thyroidectomy between 2013 and 2019. And then we were interested in evaluating more about the providers taking care of patients in these settings and the financial implications of these choices. So for our second aim, we wanted to compare the hospital settings and costs of care for propensity score matched patients who underwent same-day discharge in the same day setting and also in the overnight admission setting, And I'll carry these symbols through my presentation to help kind of guide which part I'm talking about. Our data source for this project was the healthcare cost and utilization projects, state inpatient databases, and state ambulatory surgery and services databases. We included adult patients who underwent a total thyroidectomy in the highlighted states, and excluded patients who had a diagnosis that was related to the parathyroids or extrathyroidal malignancy. We also excluded patients who had an urgent or emergent indication for admission. And then specifically for our second aim, to focus on patients who would be appropriate for same-day discharge, we excluded those treated in the inpatient setting and patients who had a complication during their index admission. For our second aim, we also focused on the darker red states because these states allowed revisit tracking for individual patients. Our exposure was admission type as determined by length of stay. Length of stay was calculated by subtracting the admission date from the discharge date, and we classified it such that a length of stay of 0 was classified as same-day discharge, length of stay of 1 was overnight admission, and length of stay of 2 or more days was inpatient admission. Our outcomes for our first aim, our trend analysis, was the change of proportion of patients treated in each setting. And for our aim 2, our matched comparison, we looked at the hospital setting, such as whether it was an academic center, a cancer center, a high-volume hospital, and also 30-day hospital costs, which we defined as the cost of the index hospitalization and any readmissions within 30 days. For our statistical methods, we evaluated our trends using the Cochrane-Armitage test of trend. And for our matched comparison, we did a propensity score match where same-day discharge patients were 1-to-1 matched with their nearest neighbor overnight admission patient. And then we compared hospital characteristics using paired odds ratios and costs using the Wilcoxon signed rank test. So for our study cohort, we assessed about 100,000 patients for eligibility. We ended up including 86,000 patients in our temporal trend analysis. Among these patients over the whole study period, 19.4% underwent surgery in a same-day discharge setting, 69.4% had an overnight admission, and 11.2% had an inpatient admission. And for our propensity score match, we considered about 37,000 patients for the match and ended up matching 9,572 same-day patients to 9,572 similar overnight admission patients. Looking at patient characteristics by admission type, we found that patients who were treated in the same-day discharge setting were more often younger, more often female, and lived slightly closer to the hospital. Diagnosis was also associated with the admission setting, such that patients with malignancy were less likely to have same-day discharge and overnight admission, and benign neoplasm were slightly more likely to have same-day or overnight admission. And similarly, neck dissection was substantially more likely to be associated with an inpatient admission. Looking at trends in admission type over time, this shows the proportion of patients treated in each setting between 2013 and 2019, with red indicating inpatient, light blue indicating overnight, and dark blue indicating same-day discharge. So we can see over time that there were no real trends in the proportion of patients who underwent care in the inpatient setting. However, we saw that the portion of patients who underwent overnight admission decreased from 72.9% to 68.8%, and there was a corresponding slight increase in the proportion of patients who underwent same-day discharge from 14.8% to 20.8%. Looking at the provider characteristics for the matched cohort, we found that patients treated in the same-day setting had a higher odds of being treated at a hospital with a larger bed size, an ACS cancer center, or a hospital with ACGME-accredited residency programs and major medical school affiliations. And they also had higher odds of being treated at a hospital in the highest volume quartile of hospitals. Finally, looking at 30-day costs, we found, you can see over here in our distribution, that light blue showing overnight again and dark blue showing same day, cost of about $7,500 for same-day discharge, about $8,500 for overnight admission. And looking at the pairwise comparison between matched patients, there was a median pairwise cost difference of $974. So there are several limitations of this study. First, we're unable to control for certain social factors like whether a person had somebody at home with them after surgery, severity of comorbidities, or operative complexity. We can't account for the costs of outpatient management. This includes emergency admissions, unfortunately. We also didn't examine differences in clinical outcomes, as this has been extensively studied in other literature. We didn't include patients treated in 2020 and beyond when practice patterns likely changed as a result of the pandemic. And finally, these results may not generalize to other US states not included in our analysis. So what are the takeaways of this study? First is that the majority of patients are observed overnight after total thyroidectomy. This may be associated with patient characteristics, such as perceived patient risk after surgery. Second, same-day patients are more likely to be treated at a cancer center, academic hospital, or high-volume hospital. It's possible that these centers have the additional resources required to safely treat patients in a same-day discharge setting, things like more extensive patient counseling or access to emergency care after hours if needed. And finally, 30-day hospital costs were higher for patients admitted overnight by about $974 on a median. We can't exactly say why patients were decided to be treated in one setting versus another, but in the setting of increased financial toxicity and cost-conscious healthcare, there's a potential opportunity here to improve care. So I'd like to thank everybody who contributed to this study and would be happy to take any questions.
Excellently presented. This paper's open for questions. I think, is that Dr. Sippel in the back?
Hi, Rebecca Sippel, University of Wisconsin. I really appreciated your talk. I think one of the greatest take-home messages is this about $1,000 savings per patient. As a program that does almost everything as an outpatient, we could use that to be able to justify the additional cost of the outpatient support that's needed to make this effective. You need to have those nurse practitioners or the outpatient support network to allow this to be successful, and your paper could be used for many programs to get those resources to allow this to be feasible.
Yeah, thank you so much for your comment. Another thing that we were talking about in our research group earlier is the importance of shared decision-making with patients, and maybe these financial considerations can also be included in these discussions with patients so that patients can kind of help weigh in on whether they want to be treated in the same-day setting or be observed for longer in the hospital.
In the back, sorry, can't see.
Rachel Slack-Havage, University of Arkansas. Thank you so much for a very nicely presented study. I was a little bit blown away to see your data about patients living 10 miles from the hospital. For me, on average, that's going to be more than a 90-minute drive. I can't even speculate what that is in miles. So how might you think the results of your study might change, the patterns look different if more states where patients were coming from many hours away to receive care were included?
Yeah, it's a really great question. Also, as someone who trains in an urban setting, someone might be 10 miles away geographically, but that can take a long time over several bridges. So, it's really interesting. I think the key take-home is that you have to consider the context of every patient. And, even some patient that lives right next to the hospital but doesn't have anybody to bring them back to the hospital if there is a complication, then that's a consideration. But it does seem to appear that distance and at least a rough capacity is being taken into account when deciding on which setting people should receive care in.
Final question.
Sam Snyder from Doctors Hospital, UTRGV, Edinburgh, Texas. I applaud your study. We need this kind of information. Change is a slow process. Going from routine inpatient to probably outpatient, it takes time and experience, and you've shown that it's in the right direction, but it has a ways to go, because some studies have shown almost 90% of these patients can be done as outpatients. So the question is, a lot of them, I think, are decided even before they get to the operation. This is going to be an inpatient, this is going to be an outpatient, etc. So were you able to pick out the data on patients that were planned for outpatient that ended up being inpatient? Or admitted even though that wasn't the initial plan?
Yeah, that's a great question. Unfortunately, we can't see that in our data. We just don't have the granularity, but Yeah, in regards to just the general slow pace of progress in this area, one thing we're thinking about is studying how practice patterns changed after the pandemic. A lot of hospitals, including our own, were pushed to perform more surgeries on an outpatient basis to conserve hospital beds. So I'm wondering if maybe the pace of adoption of same-day discharge might have changed during that time, and if these changes are sustained, into 2023 and beyond, even after this kind of bed crunch has eased a little bit.
Yeah, that's a very good point. Thank you.
Thank you so much.
Yeah, thank you.
Our last presentation is early observations with an ERAS pathway for thyroid and parathyroid surgery, moving the goalpost forward, presented by Dr. Machado on behalf of Dr. Gibson and Ogilvie from the Yale School of Medicine.
All right, good afternoon, everyone. My name is Nikita Machado, and I'm the Endocrine Surgery Fellow at Yale New Haven Health. I'd like, on behalf of my colleagues, to thank the AES and the moderators of today's session for the chance to present our work, and to Dr. Finn and her colleagues for setting us up so beautifully for this talk. So we have no disclosures. A little bit of background into the rationale for our study. Since the inception of ERAS pathways in the late 1990s, they've only become more mainstream and gained traction in a number of surgical specialties. And while the uptake in endocrine surgery is slightly newer, it's no less impressive. A recent meta-analysis that came out of the University of Pennsylvania in 2022, actually, looked at pre-existing data regarding ERAS pathways in the sphere of endocrine surgery. And out of the 6 papers that they referenced, I'd like to draw your attention to these 3 because they focus on both thyroid and parathyroid surgery, which was somewhat of the scope of our study. You'll see that they have some components in common, and this includes mainly things like preoperative education and pain management. However, the remaining components are so variable depending upon the institution and their preferences. The other thing to look at, too, is the outcomes of interest. So while the earlier papers looked at things like length of stay and cost efficacy with ERAS pathways, the more recent papers have looked at patient-centered outcomes, like mean oral postoperative morphine milligram equivalent use or postoperative nausea and vomiting. Our paper is fairly similar to some of these studies, but it's also different in that we've looked at ERAS as an adjunct for what's becoming an increasingly ambulatory endocrine surgery practice. And so for those patients who meet criteria for ERAS, the question is, can we give them interventions that can be done in a safe, patient-centered manner to optimize their experience? The timeline at Yale New Haven that you see here shows that the year prior to July 2021 is what we call our pre-ERAS implementation or control group cohort. We then rolled out the pathway in a staggered fashion over the next 6 months, giving stakeholders time to get comfortable with each intervention before we introduce the next. And then the period between March and November of 2022 is what we call our post-ERAS implementation or performance group, although I will surmise that it should actually extend to this period and beyond as we get closer to 100% compliance. Now, ERAS pathways don't really exist in a vacuum, and our protocol is a part of a larger care signature pathway that's a true multidisciplinary effort between main campus and community surgeons, anesthesiologists, nurses, administrators, schedulers, and even ERAS pathway champions whose goal is to look at our process and outcome metrics over specific intervals in time. You'll see that procedures are stratified based on the likelihood of same-day discharge. And so procedures like lobectomies or minimally invasive paras are much more likely to go home the same day, while modified radical neck dissections or revisional surgery are more likely to spend the night. And we focused our ERAS goals on the green and yellow panels that you see here to see if we can make a difference. The components of the protocol at Yale New Haven are fourfold. The pre-admission protocols are primarily nurse-driven, and so this includes nurse-led patient education and setting up expectations for that perioperative period. Patients are medically optimized either through their PCP or PAT testing, and then we recommend a carbohydrate drink the day of surgery no less than 2 hours before the operation. In the pre-op holding area, patients are given a gram of Tylenol along with celecoxib as long as it's not contraindicated. Prior to incision, our anesthesiologists perform a bilateral superficial cervical plexus block, and I've included the postoperative nausea vomiting screen down here because it now forms a part of our timeout. And so patients are prophylaxed based on their risk for postoperative nausea and vomiting. Finally, we encourage total intravenous anesthesia at the discretion of the anesthesiologist. So what did we look at? We looked at all of our thyroid and parathyroid surgeries that were performed during the study period, and this was about 675 patients. We then utilized the following inclusion and exclusion criteria to further narrow this down. So the procedures that we included are the ones that you see on the left, and then we excluded modified radical neck dissections and subtotals that were done for renal hyperparathyroidism, since those patients tend to have a more protracted hospital stay. we were left with 479 patients in the control group and 166 in the performance group, which were further then subdivided based on the number of ERAS interventions that were performed in these patients. So that leaves us with 3 broad categories, and then we looked at 2 main buckets of data. The first relates more sort of resource utilization, and so we looked at total length of stay and unanticipated postoperative admissions after surgery. The second relates more so to patient experience in PACU, and so this includes their PACU length of stay, whether or not they received a rescue antiemetic in recovery, and certain pain-related parameters, which includes their self-reported pain scores, opioid use in PACU, and then opioid use over the course of their hospital stay. The analyses that we used are listed next to each variable. So what did we find? The first thing we looked at was demographics, and so in addition to basic demographic variables, we also looked at things like their smoking history, history of opioid use, and ASA scores. And really, with the exception of BMI, there were no significant differences between the groups. We also wanted to look at what preoperative diagnoses these patients carried, and then what procedures did we really perform. The incidence of Graves, interestingly, was more significant in that high compliance ERAS group, but then again, so was the incidence of minimally invasive parathyroidectomies in those patients. Our first outcomes of interest were length of stay and unanticipated admissions. And as you can see here, there's a clear statistical improvement in both mean or median length of stay for that performance cohort. While we didn't see a true difference for all comers in those unanticipated admissions, the patient-directed or driven admissions for postoperative nausea and vomiting and discomfort were 0 in our ERAS cohort and therefore significant. When we look at this as a 3-group analysis, that trend continues, and we continue to see a decrease in both mean and median total length of stay. The other set of PACU outcomes that we looked at show a similar trend. So while there's not a significant difference in postoperative antiemetic use, there is a trend towards improvement. And then when you look at our 3 pain parameters across the board, there is a statistical difference for our performance cohort. The other thing I'd like to point out is if you look at our PACU length of stay between control and performance groups as a whole, you don't see a statistical difference. However, when we try and switch to a 3-group analysis to parse out some of that finer detail, not only are all the pain parameters still significant, but that PACU length of stay is also statistically significantly lower in our high compliance ERAS cohort. So early conclusions from our initial experience with ERAS. We found that it does decrease hospital length of stay and PACU length of stay in our high compliance ERAS patients. It decreases postoperative MME and average daily MME. And best of all, it decreases patient-requested unanticipated admissions to the hospital. Our study is unfortunately bound by all the limitations of a retrospective review when it comes to data acquisition and analysis. I will say that there is some overlap between our ERAS protocol rollout and that thing called the COVID pandemic, which accelerated a lot of our same-day discharge patterns. There are some parameters that we didn't really evaluate, and I'll talk about that more in our future directions. Next step for us as an organization includes a randomized control trial to evaluate the efficacy of individual components of this pathway, most specifically the superficial cervical block. We'd also like to perform some patient-centered outcomes analysis because they are really at the center of initiating this protocol in the first place. So we'd like to look at our 24-hour MME use postoperatively, and then even things like delayed nausea and vomiting, since a lot of our agents are shorter acting. It would also be nice to be able to evaluate this in terms of readmissions after surgery, which is something that we haven't done in this initial paper, and whether or not there's any change in complication rates. So please stay tuned. Right, thank you, everyone. I'm happy to take any questions.
Thank you. Go ahead. Yeah.
Hi, Miguel Herrera from Mexico. I can see that there is a lot of enthusiasm in sending patients home the same day in this country. And coming from a different country, I see that in countries where there is no pressure by insurance companies to send the patients home, patients remain in the hospital at least overnight. And in my practice, when I go in the afternoon and tell the patient, you are ready to go home and enjoy the traffic in the afternoon, they say, no, doctor, thank you. I'd rather stay here until tomorrow. So could you please tell me what are the benefits to the patient and being dismissed the same day of the operation?
So I will clarify this. We're not trying to really push the envelope in terms of sending everybody home. I don't think that's realistic, and I think there's a lot of factors that indicate if a patient should stay or go. But a majority of our patients would prefer to recover at home with their loved ones in a familiar setting as opposed to having to stay in the hospital if there's not really a medical reason for them to have to do so. The cost burden is another thing. Unlike most other countries, the cost of healthcare in this country is exponentially unnecessarily expensive, and so something we can do to mitigate that is always appreciated. We are trying to be careful with this, though, and if there are patients that should stay overnight or have a medical reason to do so, we'll do so without hesitation.
Go to the left side of the room.
Brad Mitchell, Dover, Delaware. Thank you very much for the nice presentation and for pushing us to think about ERAS as being appropriate in thyroid and parathyroid. I'm particularly interested in the postoperative nausea and vomiting and the impact that that has on reoperative or postoperative bleeding and the need for reoperation. I have one question for you, though. Did both of your groups have superficial cervical block, or was that just the ERAS group that had the cervical block? Did any of your patients in the control group end up with general anesthesia?
So that's a good question. Nobody in our control group had the superficial cervical plexus block. It was rolled out as part of the ERAS pathway, so only patients in the performance group would have received it.
So that'll be a major limitation in extending it to other places, because most centers aren't going to have anesthesiologists willing to do that. Surgeons should learn how to do that too, and so that we have that option available to us. Thank you.
Yeah, I agree completely.
Dr. Prange.
Sara Prange, Boston. I have no disclosures. Thanks for this great study. And to answer Dr. Herrera, as a person who resisted patients going home till COVID, I do find that patients had a lot more complications in the hospital, things that happened to them. I had one patient had a broken arm from falling in the hospital, wrong medication. So I do think there is something about safety at home as well. I wanted to ask a question about your anesthesia group. So were they resistant to trying to get them to give one kind of anesthesia rather than any kind they want? Or did you find a high compliance in that arena?
So I think you've honestly kind of hit the nail on the head as far as one of the limitations of this goes out. Trying to roll out this protocol is always going to be met with some resistance. We've had some anesthesiologists who are much more interested in learning how to do the blocks and in total intravenous anesthesia. And then we've had some that are slightly more resistant. So what we're trying to do is show them the initial data and see if maybe that's going to change minds, because I think it has to really be evidence-based for them to even want to change practice patterns.
And then I just had a quick follow-up question. Did you use Decadron in all the patients or not?
We do.
Thank you.
Yeah. Thank you so much.
Can I have 30 seconds?
Really quick, yeah. Go ahead.
Quantum San Francisco, superficial cervical block is the easiest thing to do. Okay, about 7 to 8 cc's of 0.25% Marcaine, very cheap, or you can use ropivacaine, and you put half of it at the midpoint posterior border, go below the platysma, put in half of it, and then image south, put another half of it, and you do the other side. You don't need ultrasound, you don't need anything, just palpate the area, and don't put it into the carotid or jugular. It's really, really easy. And there was a prospective randomized study that we did many, many years ago that showed that it does decrease nausea and vomiting.
Perfect. Thank you for that. Thanks. Thank you.